evening. My name is Kate Thompson. I chair the Education Committee for the British Pain Society, and we are really happy to welcome you to our webinar this evening. For any background, just anyone who wants to know a little bit more about the British Pain Society, this is who we are and this is what we aim to do in relation to pain. And if you are able to save the date, just take a note there of the British Pain Society Conference, which will be taking place on the 21st to the 23rd of April next year. I'm just going to quickly run through the housekeeping. So if you have any questions, if you could possibly just type them in the chat. We've got myself and Joe from the British Pain Society who are going to help and man the chat whilst we've got the team presenting this evening. Just to let everybody know that the webinar is being recorded. You might have just heard the notification a minute ago, and the recording will be available in the BPS YouTube channel and via the BPS website. You'll receive a link for this after the session this evening. And we will send you an evaluation form. Please, if you can take the time to complete that. We do use the feedback carefully to plan webinars, and then you will get a certificate of attendance. So that was my bit short and sweet and easy. I'm going to hand over to Professor Michelle Briggs now, who is going to introduce the session and the speakers for the evening. Thank you.
Thanks very much, Kate. I'm absolutely delighted to be here, and I'm going to just quickly share my screen. Hopefully you will be able to see my presentation. I'll just put that on slide. Oh, can people see that slides? Can people see the slide? No. Okay, I'm going to try again. You know, when you do a practice run and things seem absolutely working beautifully, and then can you see the...
Yeah, that's all good now, Michelle. Just to go to full screen. Perfect.
So can you see it as full screen now?
No, just if you click on slideshow. Yeah. Oh.
Yeah, so when I click on full screen, it doesn't seem to want to share. So I'm going to go, which is interesting. So I will just try again. That work?
The view did work. I think it's when we're going into full slideshow for some reason. It's not sharing. Will it? If you go back to the slideshow, just in the first view as you share it, and then just see whether, but almost don't go put it in slideshow mode.
Absolutely, I'll do that.
Let's see if that works.
Let's see if can you see it there?
Yes. So if you just click through the slides, but maybe don't go into slideshow mode.
Absolutely. So thank you for your patience there. My name is Michelle Briggs. I'm the Clinical Professor of Nursing at the University of Liverpool, and I sit within the Pain Research Institute. That's a little bit of the profile screen that you would see if you click through and if you Google my name and Pain Research Institute. I also have the pleasure of, I have a joint appointment. I'm also the Director of Nursing for Research and Academic Development at LUF, that's the Liverpool University Hospital NHS Foundation Trust. And in that Pain Research Institute, I have three areas that I'm working with colleagues that you will hear about their particular research journeys. This is just a slide to give you a sort of broad overview of the types of research that I do. And if you go into my profile, you'll be able to see a little bit more about that. But tonight, it's not about me. It's about you getting research funding and us helping you think about, as people who are interested in pain and improving the pain experience for patients, what what funding opportunities are available. Now, you may be aware, and during the course of this webinar, we're going to be talking about a number of fellowships. We're not talking about the pre-doctoral award. You may have heard of it as the PCAF or the pre-doctoral fellowship. They're the old systems in the NIHR. The new schemes are there are pre-doctoral awards. There are doctoral awards and postdoctoral awards. We're focusing today on people who've successfully navigated and got funding in doctoral awards and postdoctoral awards. And it's now is that couldn't be a better time to get funding when you're a nurse, a midwife, an AHP or a pharmacist. And we've got examples of nurses, physios and pharmacists here today who've been successful in navigating their way through. This is the full range of the National Institute for Health and Care Research's academic career development. There is funding available from the initial experience, the internship programs, the Insight program. An Insight program is a master's program. I'm happy to take questions on that. There's pre-PhD. As I say, this webinar is focusing on PhD and postdoc, but equally I'm happy to take questions across the whole suite. I'm hoping that this slide will give you a sense of the number and the varied offer that the NIHR Academy has to, and there is a strong desire to fund professions across the health and social care landscape. So there'll be definitely something at the point in your career, there'll be something that is dedicated to meeting your career development need within the NIHR. And we've got 3 wonderful speakers who've been able to navigate that journey. The other area is NIHR is not the only funder in this space. I'm absolutely proud to be a trustee of the Pain Relief Foundation, which supports a lot of the activity of the Pain Research Institute. But they fund, as you can see here, funding research into causes and treatment of human chronic pain and the prevention of chronic pain. And they have 2 schemes due to open this year. They're annual schemes, and they open at late October, early November. Keep an eye out for the website, bookmark the website. If you Google Pain Relief Foundation, or other search engines are available, and have a look at the Pain Relief Foundation's website. There are small grants, that's 30,000, and they're available, particularly welcome people at the early stages of their research career. But then there are also PhD studentships that are available. And there's some information here on the slide about PhD studentships. Very happy to take any questions later about that, but I'm going to stop sharing my screen and hope Sue will be able to share her screen. Because we're going to go over to Sue to talk about her experience of navigating NIHR funding for pain research. So over to you, Sue.
Thank you very much, Michelle. We'll try. It's been an interesting evening so far. So let me see if I can. Be interesting to see if it lets me share my. Right, let me see if it'll let me go into slideshow. Can you see that as full screen?
Not as full screen, but we can see them well. You can give it a try if you like. Let's see. We can see how it goes.
Okay. So thank you very much for the kind introduction, Michelle. My name's Sue. I'm a consultant nurse in breast research in Leeds, where I work as a clinical academic. So I still do clinical work, but I also do research work as well. So yes, I am very old. I qualified as a nurse over 30 years ago, but what I'm going to done lots of different training and things, a lot of it related to research. But what I wanted to concentrate on is what I've done in the last 10 years, which is about my PhD, the postdoc, and the focus is all around the National Institute for Health Research, which is what I was asked to focus on tonight. You may find there will be probably some overlap between the speakers. So how did I get into research in the first place? Or how would I advise other people to get into research? It's about being inquisitive. You do need support, usually from a line manager. If you can find any sort of little local funding to get you started, because it's about the opportunity. to do research, but it's vital, in my opinion, to keep on working clinically as well, because then you are in the right place to see what needs doing. So why did I personally get into research? Because I would hope everything we're doing, whether you're a nurse, an AHP or any other healthcare professional, we should be doing evidence-based practice, and we want to do what's best for our patients. There are more and more treatments becoming available. I specialise in breast cancer, and it's just exponentially exploded in the last few years, but we need more research to show that what we're doing is the right things and make the right changes at the right time. I would describe myself as being clinically curious, or more probably I'm just very nosy and want to know what is everything. There are challenges when you're wanting to work in research and remain clinical. There's not always any clear pathway, so I've had to pave my own. There's a lack of understanding of what we do and why we do it. There was actually no job descriptions in my trust, so we had to create, other than a research delivery nurse, which is what my day job is, we had to then create job descriptions for people doing their own research. But it's about the funding, because without that time to be able to do the research, it's very, very difficult. So the best thing I can advise about with research environment, it's about building quality partnerships and collaborations. These are just some of the people that I work with and some of the organisations.
Oh, hi, Sue. Your slides might be moving on for you, but we're still on your title slide.
Oh, yeah, blimey, I'm on to about my 5th slide. Right, okay.
That's okay. I don't know if you can click through.
Is it moving now, or is that still not doing?
I do apologise for the technical issues. We did do a full...
Right. Apologies, it's now not even stopping sharing. Can you see that now?
No.
Right, okay, I am now. Apologies, this is not going well. Right, let me just try share again then. So can you see what's in that setting?
Yes, and you're on getting into research now.
Right, so that was where I was just going. That is my background. That's what I'm talking about. That's my 10 years. That's what I was saying about getting into research.
Okay, and then we're into why I got into research and the challenges. Yeah.
So what I was saying was, sorry, these are just it's about building quality partnerships and collaborations, finding your people, your team, and it's all about finding people who specialise in your area, be that a certain disease site, be it a pain society, be it charities. I work a lot with different charities. What I'm going to focus on tonight is the National Institute for Health Research, or to give it its new title, National Institute for Health and Care Research, because we now include social care as well. So dragging it back to the pain, the reason I got into this was I knew from many years of working with breast cancer patients that a lot of them suffer from chronic post-surgical pain, and it's something that a lot of people seem to sweep over. And I wanted to know, why is this? And is it just a local problem? Is it a national problem? Because we've changed a lot of treatment, but the rates of chronic pain were still the same. So I did a local audit of nearly 120 patients, which showed that our local rate of persistent pain was about 46%. And whatever type of surgery patients had, that made no difference. It was still between a bit of everything. So basically, the audit showed that it is a problem, and we needed to look at why this was happening. And what we then did is I used that as a way of developing a PhD program of care. So we use lots of different treatments in breast cancer. Surgery was the one I was focusing on, but we also do radiotherapy, chemotherapy, hormone treatments, and to prevent recurrences and things. But every single treatment we do can cause pain, and that is a problem. Like I said, chronic pain is a big problem in survivors of breast cancer. It has a really big impact on the quality of life, and chronic pain is one of the biggest things that is most commonly that patients will report, along with reduced functionality that can either be related to the surgery or more probably the pain they get. And as we all know, chronic pain is a very complex pathway. There's lots of things that contribute to it. But even the one on your right, the nice colourful slide, that shows that chronic post-surgical pain is complicated because there's lots of different elements to it, and these are all things that we need to take into account when we're trying to develop ways of supporting patients in this area. So what did I do? So originally I got a fee scholarship from the university, and then started looking at a doctoral fellowship, and that's what I'll mention first, because that was with the National Institute of Health Research. And because without funding, you can't do it. It's just impossible. So the NIHR now have a lot of opportunities, like Michelle said, for both nurses and allied health professionals. They've actually put it into their commitment, and it's part of their strategy now to fund what they call underrepresented groups, because they know that we're on the front line, we're the ones that patients usually report problems to, but so we're in an ideal position to be able to advise on what needs doing and how to do it. As we said, there's lots of different schemes, starting from do I even want to do research, right through to being a professor and everything in between. So you'll hear those mentioned quite a few tonight. And also what the other thing NIHR are looking at is making sure that we embed research roles within the NHS. At least 5% of core NHS work is supposed to be research, and it is one of the pillars of advanced praxis. So it is something we should all be doing. And there's lots of different avenues you can go down. So like I say, what I'm going to mention first is about the fellowships, which is what I'd applied for. So like Michelle said, there are lots of schemes, pre-doctoral, doctoral, postdoctoral and professorships. Obviously, the first level that I'd gone for was the doctoral one, so that's what funds you to do your PhD. So we applied for that, and it is a process of an application. If you get through the first round of that, it's reviewed at high national level. You're then invited to an interview, and then it can take a whole year to find out if you get for the process of going through the funding. So it can be quite stressful, but it's very worthwhile doing it. And I wouldn't underestimate the amount of time it takes to develop an application. So if it is something you want to do, I would definitely recommend it. Just you need to start at least 6 months before you're thinking of submitting. So we took the money from that, developed a PhD around that, which was focused on developing a system for patients to help better manage and be better educated about the pain control following surgery. It followed the Medical Research Council and NIHR framework for developing complex interventions, because if anything involves more than one thing and you need to evaluate it, it's what's classed as a complex intervention. So we have to test it in many various ways, and I would recommend you're looking at this framework if you're thinking of developing some sort of research. We were aiming to develop a web-based intervention, which most people know what apps are. This web-based intervention is very similar, but it's just people need to be connected to the internet at the time to use them. And the reason for that is because what we wanted to do is integrate it with patients' electronic patient records. Because if patients are reporting symptoms, we need to know about it in real time in a post-surgical setting. Because most of the breast care surgery is done as a day case, and they're self-managing at home, but without the support. So that's what we're aiming to do, was to develop that support. So we developed it in 4 stages. We did a scoping review and a systematic review, which are research ways of finding out what else is already out there, what have other people done, what's good, what's bad, and it helps identify any gaps in the literature. We then worked on developing the intervention, like I say, which is a web-based self-reporting system. So we had patient focus groups. We did interviews with healthcare professionals all the way along the pathway, asking what they would need in such a support system and what they would like. We then went on to recruit to the study, which we recruited 69 patients just in Leeds, and we were looking to see, would patients use the system? Did they find it helpful? It wasn't so much about testing whether it was, the best thing since sliced bread. It was about, will patients want to use this sort of thing and find it useful? So the long and the short of it was, yes, the vast majority of patients found it very useful. So as well as filling in the questionnaires and reporting how the system worked, we also interviewed people, and they said it is something that we should continue doing. So the overall conclusion was trying to help, providing people with the right information at the right time based on the symptoms they themselves are reporting. So it's about the patients reporting in real time. We can give them the correct advice, tell them what painkillers to take, at what point a healthcare professional may need to get involved and add extra support. So then we thought, okay, well, this is working well, so we need to take it further. So we'd done the first bit that we were going to do, which was about the first phase. So where did we go from there? So what is really important is, I think, is just to keep yourself updated all the time and say, okay, has anything changed since I started doing my research and got my fellowship? This is a very up-to-date, this only came out at the start of this year, a massive over 5,000 patient breast cancer patient trial that's been running over the last 10 years or so, and I was a co-applicant on this. And as you can clearly see, this main study was looking at how often we do mammograms after somebody's had breast cancer, but we did a quality of life sub-study that nearly 5,000 ladies took part in, and at 10 years, the rate of chronic post-surgical pain is still nearly 30%. So as you can see, it's still a big problem. So I thought, okay, we know it's a problem. We've developed a system to help them. So where do we go from here? So I managed to get some charity funding from our local hospital so I could carry on working in research as a postdoc fellow. And then I went back to the NIHR and said, okay, what programs do they have that we could put an application in to get further funding to allow us to test this system further? That is a list of just the actual grant programs that they do, these aren't personal awards, these are to fund research. And the one that we went for was a call for research for patient benefit. Now, this was a specific call they put out for nurses. They've also done a follow-up one for allied health professionals and other underrepresented groups. So we were successful in getting that, and that was a 2-stage application. Put a first round in. If you get through the first round, you're then invited to put a full application in, and then you find out if you've been awarded it. And that whole process takes a minimum of 6 months. So again, I would advise you plan well in advance and know what you're thinking of doing. So then we were then successful in getting this RFPB grant, of which Michelle is a co-applicant from Liverpool. So what we're doing is looking to see if we can pick this system up out of Leeds and embed it into other NHS systems. Because the thing to remember, if you're applying to the NIHR, what they're looking for is things that will work in the NHS. That's where their funding remit is. It's about supporting research in the NHS, but looking for treatments that will have a positive impact on patients and the wider NHS. So that's why we're saying, yes, this system works in one hospital. Can we make it work in a wider area? So we're currently in the process of setting this up, and it will be randomised, whereas the previous feasibility study allowed patients to choose whether they wanted to use the intervention or not. This will randomise them. So that's a different thing again. It's will patients still want to take part in a trial where they don't get a choice. So that's we're in set up for that at the moment. So but I thought, okay, well, I need to do more to further my work in research and how can I take this further. So then I applied for a leadership fellowship and an educational one, and was unsuccessful in those. So, okay, well, let's go back to the NIHR, see what other awards they do. And this was a brand new one that came out about 18 months ago. And this is for people who are postdoctoral. So I was lucky that I could then apply for this. And what this is, a Senior Clinical and Practitioner Researcher Award. It's a very flexible award. It's a personal award. It's for you. It doesn't pay for research, but it protects your time, so you can buy out some of your clinical time so you can dedicate that purely to research. You can get up to 50% of your time. I'm funded at 40%, and you can take it over 2 to 5 years. But it allows you to, allows you to then the time to develop the research projects and grants. You can do other training. So I'm doing some leadership training, I'm doing some statistics training, health economics training, all the things that you will need to go on to develop further grant applications. So I also applied for one of those. Unfortunately, I was successful in getting that. So I've now got 5 years of funding at 40%, which gives me that dedicated time to work on research. So with the ePain-Q system, I say it's going to be tested as part of an RFPB grant. But in the longer term, where do we go from there? And then what I would be doing is I'd be going back to the NIHR funding programs and say, okay, where does it fit into all these? And it may well be that we apply for, I can do this, like Michelle says, as an advanced award, because that does fund research, or we can fit it into one of these other awards. Or probably more likely it will, let's say, go into a postdoctoral award. And that's where we're probably looking. So you can see that NIHR has helped fund all the way through the pathway, and that's what's been incredibly helpful. So for the next steps for me I'm using the NIHR SCAPRA as a way of building my collaborations, giving me that dedicated research time to be able to build up other grants, other experience and all that. The RFPB is paying for the actual study that we're doing to test a system. Having any sort of grant or fellowship from the NIHR then gives you access to you are automatically become a member of the academy, which gives you access to even more training and support. You can be a mentor, you can be a mentee. There's other opportunities to apply for courses that only academy members can apply for. And it's about using this time wisely to build your links to other clinical academics. I'm also now supervising and mentoring others who are coming up through the pathway, and something like this webinar is part of that. It's passing on the experience, both the good and the bad, because what we really want to do at the end of the day is make sure that research is embedded in every department, in every hospital in the NHS. And these are just a few of my favourite 2 quotes I wanted to finish with. So I think these sum up both research and trying to do work within the NHS. So it is very challenging, but if you don't ever challenge yourself, we'll never be able to change anything. So I think it's challenging, it can be difficult, but go for it. And sometimes you get into it and you think, oh, I'm drowning here, why am I doing this? But as T.S. Eliot said, if you're not in over your head, how do you know how tall you are? And it also teaches you to swim very quickly. So thank you very much for that, and I hope that's been of some use, and I'm happy to take any questions.
Thank you. Thank you, Sue. That's a really great overview of a nurse's journey through pain research. And I'm just checking the chat now. As I say, please do pop questions in to the chat. At the moment, I can't see any questions that are typed in the chat, but if anybody has a question for Sue, please do type that in. If not, if we haven't got any questions at this moment, and while you're thinking about questions, I'm going to hand over to Selina. And what we may do is, by all means, don't feel like you've, oh, hang on, wow, Sue, it's been so, oh yeah, also when Anika met you at NAPS, and I wish I'd spoken to you more. She wants to ask, what are your day-to-day clinical activities? What do they look like?
This is where it really cooks people noodle about what I do for a job, because with the clinical academic, you have part is your NHS day job and part is research. But what confuses people is my NHS job is as a research nurse, but that is research delivery. So what I do is I deliver other people's research. So I still see patients, I still go to clinics, I go to the ward and things, and I recruit patients to trials. But then the academic side of me is developing my own trials and delivering on those. So I do still do a bit of both.
And how did you get managers on board?
Now, I think as you get older, you do get more, you do feel a bit more confident to ask. And I would always say, do ask. The worst somebody's going to say to you is no. And quite often people don't mention these opportunities because they're not aware of them themselves. So I would go to them, find out everything you can about it and say, would you support me if I applied for this? Because you do have to have your support, and you have to mention a line manager, and quite often your hospital has to fill in something on the NIHR application form to say they will support you. But the massive advantage of this is it buys out your time. The part of the NIHR fellowships and grants pays for your salary, so they can replace you. So in a way, it's very difficult, or it's a challenge for them to not let you have the opportunity because it's funded. You're not asking them to pay for it. So I would definitely go for it and ask.
I would ask early. Don't feel like you have to have a fully worked up idea before you start having conversations with your managers and work up. One of the things that I know that Sue did was right at the very beginning, the audit data really helped in terms of focusing managers. Julie's saying that how did you choose your study design? It's interesting that you didn't randomize the feasibility study. That's an interesting question.
Absolutely, and it is something we considered at the time, but because at the time, this was pre-COVID, So at the time, it was very difficult to get funding, both for pain, but also in web-based intervention in the digital world, because before COVID, it was considered quite new and not many people did it. So what we wanted to do is see if patients had an appetite for using this sort of system, and whether they would then would they want to do the trial, would they then actually use the system. So it was more about, can this sort of thing be used, and can it be used in the NHS, rather than is it effective? So we wanted patients to be able to choose, because that would tell us a lot about their level of interest. And I say 60 out of 69 patients chose to use it. So that gave us that clear indication that it was something that was worth testing. And that's why we're now going on to as an RCT, so we can directly compare those who do and don't use it.
Thanks, Sue. So thank you for those questions. That's really added value to our webinar. So thank you so much for those who put questions in the chat. Selina, over to you.
Okay, I'll attempt to share my screen, see how we go. And people see that?
Yeah, so
try the presentation mode, see whether we can get it to work. We can always go back again if it doesn't.
Can you see that?
Yes, if you swap
if you can swap the
yes.
Absolutely, you get a badge for being able to share well.
Okay, we're finally there. Okay, so thank you for inviting me to speak and to have a chance tonight to sort of share some experience. I'm going to go through sort of just explaining sort of some of my funding over the years, the successes and also the failures, because I think I've learned so much from that, and I think that's really important as well. So a pain specialist physio, and I work at Walton Centre, but I have a split role. So I am 60% clinical, so 3 days a week I work as a pain physio at Walton Centre, and 2 days a week I have protected research time. And really, at the Walton Centre, it's a large pain clinic. So in the Walton Centre, I have chance to work on multidisciplinary team programs, such as the pain management programs, and also deliver one-to-one work in physio outpatients. And I really think that informs my research and really where I want to be, and has really given me the passion in the first place to want to be involved in research. So my focus is around improving access to healthcare for people with chronic pain, and particularly around pelvic pain, and AHP research out there as well. So I thought it'd be quite useful to help illustrate my experience by showing my journey. So I've just presented it slightly different from Sue, so you work across the page. But at the top here, you can sort of see my qualifications and sort of where I've worked, and I've thrown 2 kids in there as well because they've been part of my journey as well. So I qualified back in 2000. I've been a physio for quite some time now, but quite early on, within 3 years of qualifying, I worked at the Walton Centre. I initially went on a secondment, and I worked in the neuromodulation service and the pain service. And then since 2003, I've never left. I've always worked in pain there, and that's and I did my MSc there at the Walton Centre, and I also then went on to do my PhD and then got this split role. And part of why I've worked in pain so long is I genuinely love this area, but also I think what's really helped has been having the privilege to be able to work on projects, to develop projects, and be part of service development in a service that is constantly evolving. And I think I've really enjoyed that, building a project. I really liked having to research what should be included in a view service development, what that service needs, what's best for patients, and where the gaps are. And as I've gone further along now, I've realised that they are really key skills in terms of research as well. So I haven't really switched. I've just been able to use my skills in a different way. Along the bottom here in yellow, I've highlighted some of my successful funding. So you can see there's a bit of variety there. I've had some NIHR bigger grants, but I've also had some smaller pots of money as well. So the first one, RCF, is research capacity funding. And then I've had some PPI money, and I've also had some money from the Pain Research Institute, which Michelle mentioned as well. And what I want to really highlight from that is that the smaller pots have been equally as important. They've allowed me to undertake that work, they've allowed me to maintain that momentum, and they've really helped to build stronger projects. We've had, a lot of unsuccessful funding applications as well. So I've put them in grey at the bottom. And I think in terms of the unsuccessful funding pots, they've really been a huge part of the journey, and they've been as valuable in terms of learning and developing as the successful pots. And they've really helped to shape sort of my focus and hopefully make me a researcher. And you can see as well that I've had more successes moving along. So hopefully that continues as well. So my first major grant was an NIHR Research Patient Benefit grant, and it focused on peripheral nerve stimulation for peripheral neuropathic pain. So it doesn't really flow off the tongue very easily, but what was crucial in securing that award was really the very early clinical work, a bit like what we noticed was some people with very localized pain and sensitivity responded well to this form of peripheral nerve stimulation. And that observation led us to ask, is there a genuine therapeutic effect? And could this be something that we could more widely use? How could we manage our pathways so that the right patients were getting the right treatment? And so to explore this a little bit further, we were able to obtain amount of industry funding to conduct a structured audit, so to look at patients with this treatment in a little bit more of a systematic way. And it was an audit, but the results were promising and we had some positive outcomes. We wrote up the findings and we published the work. What that then led to was, well, some patients we knew benefit from this, but we still couldn't access funding for patients to be able to use this in the long term because there just wasn't any good evidence really there to support it. And so at that point, somewhat maybe a little bit reluctantly and quite a firm push from one of the consultants we worked with, I was convinced to present the audit findings at the Pain Research Institute as part of a research meeting. And the research meeting was a little bit intimidating. There was lots of academics and lots of research, but actually it was such a supportive environment. I got a lot of positive feedback, and that's really where the momentum for the idea started to build. And it was a real turning point for the project, but also my research development. So encouraged to apply for research funding. I think one of the important things was mentorship and support, and they were really crucial at getting me across the line. The mentorship, as I mentioned, obviously gave me the big push. But then also, as Sue mentioned, and as some of the questions came up, I really needed clinical support. So that involved asking permission about whether I would be able to take time off, but all to do sort of prep work and in conversation with my managers. But my managers wanted to know what I'd be committing to, what logistically this would look like, how much clinical time would that involve, and how I could manage that. It really needs to, before even speaking to my managers, to have a chat with some colleagues to see if people would be prepared to do overtime or do extra work to backfill me so that we wouldn't have to go out to advert for smaller pots of money. So I was able to go to my manager with, these people are prepared to do this work. If I get the money, this will be able to do this. This is how it could look. So I'd taken some of the risks out. I also had research mentorship from one of the consultants here who has been so supportive throughout my research career, but also the research unit as well. Here we're at the Walton Centre, we're really supportive, and the research design service. As Sue and Michelle have said, there's lots of funding pots out there, and knowing where the hell to start, which pot suits you, whether you're going to be successful in that, can be a real difficult landscape to navigate, and that support in that area really helped me to navigate that research landscape and the direction to identify what funding stream would be the right fit for me. Once I'd identified funding, I think applying smaller pots of money were really important to provide the protected time to allow me to prepare an application. As Sue mentioned, it takes a while to prepare this application, and I was able to apply for some research capacity money, which gave me half a day a week for 6 months to build together an application, and that allowed me to have my first experience of juggling clinical and research time and what would be involved in that. I also got some patient and public engagement money from the Research Support Service to do some preparatory work and to talk to people whether this is something that they would want. And we also were able to contact industry and potentially line them up to provide the devices for free to conduct the trial, which was a huge sort of incentive as well for the research study. So the different pots there were really vital in terms of protecting my time, allowing me to have the time to do that, but also identifying further things that would build on the audit and strengthen a future application. And that allowed me to apply. But I also wasn't successful first time. And I think having built the research team and having those people sort of in my corner really helped at this point, because they encouraged me to go again. They encouraged me to use the feedback and to reapply. And I think if I hadn't had people saying that is what happens with research, I may have just down-tooled at that point. So that was so important. And the second time we were successful. Because we were successful with the money as well in getting a large grant from the Research for Patient Benefit, people said, well, you're doing a lot of work anyway. Why don't you make that part of a PhD and do your PhD at the same time? And I went, okay, that sounds sensible. Yes. So I decided, I built my PhD work around that project as well. So I was able to do both at the same time. And the funding enabled me, the project we did was a randomised patient assessor blinded sham controlled trial where we randomised 76 patients to a sham intervention or the actual intervention. And as part of the work as well, and to inform my PhD, we also explored the underlying potential mechanisms. And to do this, we partnered with neurophysiologists at Maastricht University and Manchester University. And these collaborations were really important. They not only broadened the scope and the impact of the research, but they really showed me at a very early point how valuable partnerships are in enhancing both the scientific depth of your work, but also the real world relevance as well. So it helped me to understand the mechanisms a lot more, which informed my PhD and led to this publication. And obviously I was able to get my PhD as well. The results of the study showed that stimulation wasn't actually associated with a strong overall effect. So we didn't have a hugely positive outcome, but what we did see there was a trend towards potential benefit, and it raised more questions. It highlighted that treatment priorities and patient selection needed further optimization. And what that actually led to was revising how the treatment was offered to patients. And this was a really good learning point for me. It really showed that stepping out of my comfort zone, taking opportunities, I could start to answer some of those important clinical questions I had at the beginning, and it really helped me to influence our practice. It also gave me confidence that research isn't just for academics, that clinicians absolutely have a place in research. And actually, the most meaningful research often comes from partnerships between both worlds. And towards the end of my PhD, I began to think, well, what next? And as I mentioned, I really enjoy service developments, and I've been fortunate to be leader on a couple of them. And one of the service developments that I was really involved with was developing our pelvic pain management programme and the development of our physio-pelvic one-to-one clinics. And I felt that this was a huge unmet area, an area that I felt that the pain management programmes and the one-to-one work could really change. And this became sort of an area I wanted to explore a little bit more. So I knew that chronic pelvic pain was a really common condition. It impacts 1 in 10 women. So we have huge numbers of women in the UK suffering and struggling with pelvic pain. And as Sue said, pain affects people in lots of different ways. So it can have a huge and quite wide-ranging impact. But some of the things that we look at in our treatments target some of these impact areas. And so I felt that there was more that we could be doing to support people. I also saw that for many women with pelvic pain, their clinical journey looks a little bit like this. A lot of people feel that they go around in circles, they're going in knots. And as Sue mentioned, this is also, it's partly due to a lack of awareness, but also evidence about sort of different clinical treatments and the support that can be provided. And what really struck me is how many patients weren't getting access to physio or management addresses the wider impact of their pain early enough. And I wanted to see if we could maybe intervene earlier and offer more holistic care earlier. And that's been the sort of drive of my future work, really. Having a PhD has certainly given me the research skills. It's opened me up to more funding opportunities. Like Sue mentioned, different funding opportunities are only open to postdocs. It's also shown that I'm a competent researcher, and potential for collaborations therefore grows. And working with others and leading on some of those previously mentioned unsuccessful applications has really shown me what it takes to build sort of a project, what needs to be involved, and to hone my grant writing skills, but also my research skills as well. So building, in terms of what I needed to do next, it's about, I needed to really build my understanding of the problem a little bit more, and that meant exploring the wider context and the specific needs of the patient group. So to do this, exploring the issue, gathering insights, so that I can start to shape a meaningful and well thought plan out of an idea. I'd already started to build a network of contacts, and this allowed me, through the various networks I was involved in, to connect with people who were working in that area, but also to identify new mentors that would help me become more research independent as well, and worked in this area. Also through the networks, I learned about different funding opportunities, and I learned about the NIHR bridging scheme, which was something that I was able to apply for, and it gave me funding for a year, which allowed me to continue to buy my 2 days a week out to really work in this area and develop the project. And it was really nice being able to chat to people who had experience of the bridging scheme as well, or experience of those next steps, and realise where my focus would be and what that may look like as well. So through my work, I've been able to provide evidence that there's gaps in terms of the pathway for managing pain associated with endometriosis, particularly around services varying and access to appropriate services. So the road for patients often looks patchy or delayed, as this picture sort of illustrates. Part of my work has identified that secondary care could be a crucial target for change, as this is the typical point where a lot of people have their first point of consistent specialist access. And so it's got a real potential to reduce the long-term burden if we're able to offer support at this stage. And so to take this work forward, I started to look at different funding streams, and I applied to 2 NIHR funding streams. The NIHR ACAF, which it's no more, it's a postdoc award now. And the funding stream that Sue's already mentioned, the SCAPRA. The Advanced Clinical Fellowship allows you to conduct a project and also develops you as a research leader. But as Sue mentioned, the SCAPRA doesn't fund your research, but allows you to engage in research activity and develop as a research leader. So I applied for both funding streams. You can see from this letter, unfortunately, I wasn't successful with the ACAF application. But the process there, as Sue says, is a long process. I applied, I was shortlisted for interview, I had an interview and lots of prep work for that. And then the result was my interview wasn't successful. But the process there really helped to clarify my thinking. It really helped to sharpen my focus on projects. And it really helped me to rethink where I wanted to be and what could I use to make my research more meaningful. So as this slide illustrates, rejection is redirection. And the feedback really highlighted areas where I could strengthen my proposal and pointed me in the direction where I felt really quite strongly that I need to do a bit more further pilot work and a bit more clarity and direction, how I can make my research a lot clearer and a lot more focused, and also reduce some of the risks that maybe the reviewers had initially seen. At the same time, I was successful with the NIHR SCRAPRA funding, and this has really given me a real opportunity to harness that redirection and to continue to develop my work with new insight, with support and new networks as well. So the SCAPRA provides, it's provided me with 0.4 working time equivalent, so 2 days a week for 5 years. And this will allow me to lead on developing new research projects and funding bids. I put in my application as well, I wanted to do a lot more stakeholder engagement and a lot more lived experience involvement. So I've really got that strong patient narrative throughout my research, and I'm really designing research that meets the needs of the people it serves. It's also going to help me build and widen my collaborations nationally, but also internationally, and also undertake training, as Sue said, so that I can strengthen my areas that maybe are a little bit weaker, the research skills I need to develop, so that I can start to build research that looks at addressing these gaps in these areas. So some of the work I was funded from June, so my funding started from the beginning of June. So I've already started to work on a few projects sort of in this area. So one of the funding projects that I've been funded for is a small award from the Physio Obs and Gynae Physiotherapy Society, specifically looking at flare-ups and exploring sort of how people can successfully navigate flare-ups, and maybe the underlying mechanisms may be there. So I put the funding in before I found out about the SCAPRA. So during the SCAPRA now, what I've been able to do is really work on the ethics, pull together my patient group, and start to get that sponsorship approval and things in place so that I'm ready to go in the next month on this project. We'd also submitted, I was a co-applicant on an NIHR health technology assessment looking at the cost effectiveness of pain management programs for endometriosis, and we got through to the second stage. So the funding for that will start in January, so I'll have a lot of work there to do to help develop and design the program there and look at the efficacy of things. And then other things that are in preparation are a health service design and research award, where we're looking at recommendations and better description of how pain management programs should be delivered and tailored for people with endometriosis, and demonstrate some of the outcomes and how that works in that area. And also, I would like to put myself through the ACAF process again and go for a postdoctoral fellowship. I've got the feedback there on how to make a stronger application, and to focus that a little bit more. So at the moment, I'm underdoing quite a lot of preparatory work looking at that. I'm doing some qualitative interviews with physios, exploring their practice of treating pelvic pain. I'm doing some surveys to look at current practice and some audits to better define the patient population. And I'm also going to do some focus groups with patients who have been seen in secondary care as well, to further explore their experience and maybe what they feel would be useful at that point in their care as well. So it's really allowed me to sort of widen sort of what I've been able to do and build an area of research that I'm involved in. So I suppose lessons learned, I think research is deeply rewarding. It has a huge potential to make a difference to the people we support. But I think what's really important is asking the right questions, the ones that truly matter. And to do that, we need to involve all stakeholders. And that's people with lived experience, but also clinicians, researchers and services as well. I think progress as well doesn't only come from big grants. Sometimes it's the smaller pots of funding in between that allow you to keep going, to pilot ideas, to build momentum, and to generate the evidence that informs then the larger grants. I'd also say, and I think I learned quite early on, that research is a team sport. It's not an individual sport. You need to connect with people. You need the experiences as perspectives of those around you to really enrich your work. And that may be patients, researchers, clinicians that have walked the same path as you, or where you would like to be. And I think to build those connections, you have to say yes to opportunities. You have to be open to learning. You also have to be persistent. You have to roll with rejection and use each knockback as a learning lesson as well. I think I've learned so much from the unsuccessful grants that I've been able to then take forward into my successes. I think take-home messages I'd like to leave people with are clinicians in research really do matter. Start small. Small steps build confidence, but also credibility. Support and mentorship is out there. I've been so lucky in terms of my support and mentorship, and that's something that I'd like to pay forward as well. So again, that support and mentorship further increases support and mentorship and wider capacity. I'd say if we get rejected, just see it as an opportunity. It's definitely not the end of the road. It usually gives you a clearer focus. And funded research does improve care, but it also has the opportunity to build careers, strengthen collaborations, and create a real lasting impact. So I'd like to acknowledge some of the people that have helped me along the way. If I put all the names on that slide, would just be ridiculous to read. So I've just put some of the names, but I know I've missed some people off. And then I've also just put a few little plugs on. I'm involved with the Physio Pain Association, and we are due to launch our small research bursary in the next couple of weeks. It's a small pocket of money. It's £1,000 towards research, doing a small project, but that can be a really nice early step or support an ongoing project. And also I'm involved with CAPA. And the CAPA website, if you're an allied health professional, if you're not even, is a really good website. On there they've got resources, they've got a directory of AHP funding, they've got a list of research processors that can be approached for mentorship, and also some research resources, so the research capacity framework and other useful tools there that can help you to navigate research. So thank you very much, and I will stop sharing my screen.
Thank you, Selina. That's a really good overview, and as Joanne's saying, it's a fantastic journey so far, and you're doing exactly what I was hoping to do, is to inspire the clinicians that this is an achievable thing. I love your phrase. It's rejection is redirection. I think I'm going to be taking that. So we've got a question. You said about research not being just for academics. When were you, at the beginning of your career, how did you aspire to work in research? Did you have a clear idea? How do you find juggling research, family, PhD?
There's lots of questions in there. That's not one question.
There's lots of questions in there. Yeah, but
I think I didn't see myself as a researcher. I thought, oh, doing an audit, writing up a poster was something I can do. But when we did the audit initially for the peripheral nerve stimulation, somebody said, well, don't just stop with a poster, do a publication, and sort of almost supported me to do sort of that publication. And with that, I thought, oh, right, okay. That was sort of my first sort of taste. But then it was very much, well, if you can do a publication, right, where do we take this next? And that push to then present my idea to researchers and academics and to get their feedback and to allow an idea to take a little bit of shape, but also to be guided a little bit with that, I think was really, really important. So that was sort of my sort of first step. So it wasn't something I ever planned to do. It was kind of something I got a bit of a nudge into, but actually having done it, I don't think I'd look back again now. I think I think it was definitely the right choice. Juggling family, PhD, and all of those things is a bit of a juggling act. Through your PhD journey, there are points where you feel, oh God, there's so much to do, and other points where it's kind of, I felt, this is all right. This is fine. And I can only sort of thank my very understanding husband for giving me bits of bobs of time, but also I think being part of those networks I mentioned was really helpful at that point, knowing that other people and other PhD students, other people juggling research struggle with things, and knowing sort of that they've navigated things, I think is really important when you're trying to balance things. And sometimes you feel like you're balancing really well. Sometimes you feel, oh my God, I'm going to drop a ball in a minute. And sometimes we do, and I think that's okay.
Thanks, Selina. And I think that the message from Sue and yourself as well is that this isn't a solo activity, and that actually the more people you have to help you, the easier it gets with that juggling. So I'm aware of time, and we're going to move on to Neetu, our third speaker. Thank you for staying with us and engaging with us on the chat. Neetu, I'm going to hand over for you to share your screen and talk about your experience from a pharmacy point of view.
Thank you, Michelle. I'm just going to start by sharing my screen. Can you see my slides?
Yes.
Okay. So yeah, good evening, everyone. Yeah, I'd just like to say I'm delighted to be here to present my journey on pain research. So I'm Neetu Bansal. I am a pharmacist by background, currently working as a lecturer in pharmacy practice at the University of Manchester. So a little bit about me. I am a clinical academic pharmacist and a lecturer in pharmacy practice at the University of Manchester. And I've got a special interest in medicine's optimization and pain management across the perioperative journey. So my background, I've largely worked as a surgical pharmacist for over a decade at the Manchester University hospitals. And I was designated as a fellow of the Royal Pharmaceutical Society for my distinction in profession, which I largely attribute to my research and my clinical practice. I also hold a patient safety award from the NIHR Greater Manchester Patient Safety Research Centre. And I'm also co-chair of the UKCPA, which is a hospital national group that represents hospital pharmacists of the surgery and theatres group, and acute pain lead as well. I have recently completed an NIHR clinical doctoral research fellowship, so very recently completed my PhD viva this summer, with my research focused on optimizing post-operative opioid use, otherwise known as the eTaper study, which I'll give you an insight into during this talk. Prior to this, I was successful in securing an NIHR pre-doctoral fellowship. So what Michelle presented earlier in terms of my journey, so I started off with a pre-doctoral, moved on to then the doctoral. I'd also like to add, as one of the first pharmacists to be appointed onto the NICE Fellows and Scholars Program, and I'll tell you a little bit more about that as well. So this is the start of my journey. So I started as a surgical pharmacist back in Manchester in 2012, having worked as a hospital pharmacist since graduation in 2002 in various hospitals down south, and then taken on this role as a surgical pharmacist in Manchester. And my role was specifically looking at enhanced recovery pathways. The enhanced recovery pathways were first rolled out in the UK back in the early 2000s. And the whole idea was to improve patient outcomes, patient experience, reduce length of stay. So sitting around a multidisciplinary group, and we're talking about how each profession can have an input. And what I found that there wasn't any ownership from pharmacists. And I was keen to demonstrate what value they can add to enhanced recovery. pathways, and I came across this nice fellows and scholars scheme, and I applied to this, and I was one of the first pharmacists in the country to be successful. With this scheme, I was able to demonstrate the impact of pharmacist involvement within these pathways to improve patient care. I was able to demonstrate a reduction in length of stay with pharmacist involvement and a reduction in post-operative complications. This then led me to realize actually the value that pharmacists can add to research. And this was my first flavor of research into clinical practice. And I was actually quite amazed at the impact that a little bit of research quality improvement could have. So this service has now been recognized nationally, internationally as well. So then I started to think, how can I take my research forward? So one thing that really struck me was we're discharging patients home earlier, which is great. We're reducing length of stay. But what we're doing is we're discharging patients home on opioids. So they're going home on opioids. And they are then basically there's little review that's taking place. So that led to me to then apply for the NIHR doctoral research fellowship to undertake my PhD. And I was not successful the first time, and I did submit a second application, basically improved on the feedback that I was given, and I was successful the second time. And Michelle has been my clinical supervisor right from the start of my pre-doctoral journey, so she can empathize with me on this. So this is where it all started. So this was the problem. So a surgical pharmacist on the wards, and I recall numerous heart-sinking occasions where I was reviewing patients' medications, and they were being admitted on opioids that were prescribed on their previous hospital admission. And I remember this one patient really clearly, where they had a full bag of medications with him, and he had a box of oxycodone. And I questioned him to say, why are you still taking this? And he had no idea that he was on an opioid. And that really made me think we need to do something about this. And that's where it all started. So just a little bit of background. It takes as little as 2 weeks for patients to become dependent on opioids, and it can take as little as 3 months for patients to become addicted to opioids. Now, at the start of when I was going to undertake my PhD, most of the evidence we had on the long-term use of opioids came from Northern American countries, and we had very little understanding of what was the prevalence, what was the scale of the problem in the UK. Although we were aware that we are in the midst of a problem, that we do have a problem, we didn't know the scale of the problem. And that set me on a journey to let's investigate this. So one of the first steps I did was let's try and understand what chronic post-surgical pain is, what persistent post-operative opioid use is. And what I found was that we didn't really know what the prevalence was. There wasn't a true handle on this. So I conducted like an umbrella review or a review of systematic reviews. And this showed that there isn't a single definition of either of these terms, and there is a lots of wide variation. And that then informed the next stage of my research, so which I haven't presented here, but I then undertook a large-scale study using a national data from CPRD, some of you may be familiar with. So basically it's anonymized GP practice data, and I looked at the prevalence of opioid use and the risk factors of patients who are most likely to end up on opioids. I then went on to have a look at what interventions are effective. So we've got patients on opioids. What interventions are effective in reducing opioid use post-surgery? To undertake this research, I worked very closely with health psychologists, which was great for me. Again, having that collaboration, stepping outside of my comfort zone, working with different professions who come from it from a different angle. So I used the behavior change taxonomy to identify interventions which are most effective in reducing opioid use. And my results indicated interventions which are led by healthcare professionals, interventions which are guided, educational interventions are most effective in reducing opioid use after surgery. I then went on to took this information that obviously I'd learned from my systematic reviews to actually co-design an intervention using a methodology known as the experience-based co-design. So the experience-based co-design is a methodology I really enjoyed using, and largely because it gave me the opportunity to work very closely with patients as well as healthcare professionals, so experts working in pain medicine. And what I really enjoyed about this is bringing the two groups together and really discussing the problem and bringing my research to life. And that's what I really, really enjoyed. The first stage of my experience-based co-design was really to understand what are the barriers, what are the enablers of post-operative pain management, both from a patient perspective and from a healthcare professional perspective. What I found was in terms of barriers, barriers were in terms of limited information given to patients prior to surgery. Barriers were there wasn't that continuity of care from secondary care to primary care. So patients felt that there was a lack of communication in that space. And enablers we found were patients really felt pharmacist-led reviews were helpful, particularly in primary care. They found that when their medication was reviewed by a pharmacist, they had the opportunity to discuss tapering plans and come off their opioids. They were better educated as well. And also what emerged was the use of digital interventions or digital tools were enablers in reducing opioid use. This then led to me working with, again, a large team, working with Health Innovation Manchester, working with the CCG, again, to develop an indicator or a tool to identify those patients who are prescribed opioids after surgery in primary care in a timely and appropriate manner to prevent this problem of long-term dependency. So I've got a short video with you to share, and I do apologize, the sound is not working this evening, but I will try again. Sorry, so that just gives you a brief insight into this intervention that we've developed. So I won't go into this detail into this slide, but I also like to mention that I've also been successful in securing a small pot of money from the NIHR, the Greater Manchester PSRC, where we've developed prescribing indicators related to opioids in patients with chronic pain. So that was research I was able to do alongside my PhD as well. And what I've learned through this journey, very similar to what Sue and Selina have already said, just to emphasize the positive impact research has on clinical practice. And at the start of this journey, I had no idea on what impact this would be, but like Selina said, research is not just for academics. We can have a big impact as well, and the importance of interdisciplinary collaboration. And what I'd really like to say is what I've really found is just thinking outside the box, thinking who do I need to work with to make this happen. And I've also, I think through this process, I've developed good leadership skills. And I think very important to balance priorities along this. And it's surprising just the number of skills that you do gain along this journey. So thank you for listening. I'm happy to take any questions.
Unmute, that's always a good idea. Thank you so much, Neetu, for another really great insight into, I'm going to keep an eye on the chat. There's some people who are already networking within the chat, so that's absolutely brilliant if people want to connect up. As Joe says, that if you want to email info@britishpainsociety.org, then we can, if you want to connect up with Neetu or Sue or Selina in terms of the work that they've been doing, or indeed myself in any of the work that we're doing, I think please do put other comments, compliments, always lovely to have, but also criticisms. You know, the things that I've taken from this webinar as I've been listening to it is small pots of money make a significant difference to the journey. So and they're stepping stones to bigger things. So thank you, Selina, for highlighting the physiotherapy money. Pharmacy also have pots of money, and so absolutely look for small grants. Build your teams and be bold about reaching out for help. And all of the another uniting thing through all of our speakers are the when they reached out to academics. I think it was Selina who said, oh, when she presented to an academic forum, it can be intimidating, but actually it was incredibly supportive. And I think that's my normal experience, is that people want to collaborate, and people absolutely need a clinician's contribution to making meaningful research. And that was one of the points that Sue was making, was that actually the best, most meaningful research is when we're working in partnership with academia and clinicians. And then the other absolutely that the passion for making a difference to patients, a connecting theme of all of these presentations were clinicians working with patients in pain and thinking we could do better. There could be, that we could do better. And it reminds me of that Maya Angelou quote of, when we know better, we do better. I'm completely misquoting Maya Angelou there, I do apologise. But it's a case of knowing how well we are doing, but knowing how much research can make a difference to patients in our daily practice. Difficult question. What would you all recommend not to do? That's a fabulous question from Patrice. So I'm gonna open that out to each individual. For me, I would say what not to do is think that you haven't got something significant to say. That would be my bit of advice. But Sue, what would you not do?
That was more or less what I was going to say. As people know me, probably like Michelle and Kate, there isn't much I won't do. But I think it's don't underestimate what you can do yourself. Because it's quite easy to think, oh, well, research is what somebody else does, or I don't have the experience, I don't have the knowledge. So don't underestimate what you can do and what you can achieve. And just ask people for support, because there are people out there who are more than happy to help.
Neetu, what about you? What would you advise not to do?
I'd probably say what I would from experience is not to rush an application and just to think it through, especially when you're applying. I found, this is my own experience, to the NIHR, it's always about telling a story, and it's getting that story right when you're doing your application. But like Sue said, I would say, no idea is too small. If you've got a research idea, it can always make a difference. So make sure you put it out there.
Absolutely. And Selina, what would be your don't do?
I suppose building on what the guys have said, really, don't think just because you don't know something that you can't do some work in that area. I think I've learned sort of, well, I can't do that because I don't know the qualitative methods, I don't know this, but actually that's part of your journey, learning those things and collaborating with people that will help and support your skills. So you don't have to know everything to get something done, so don't let that put you off.
That's great advice. And Kate, what about yourself?
I mean, I was going to sort of echo what Neetu said about not rushing an application. I think I've been guilty of that previously, and that thinking I've always got more time than I have, and actually just take time with it and almost be ahead of it. I mean, funding calls tend to come out annually, don't they? Or some NIHR ones 3 times a year, actually. So sometimes to know they're coming and almost be a little bit ahead of it is quite useful, to think, rather than I've seen it and it's out and there's a deadline, that will probably come round again. So to almost just use that first deadline to just motivate you to start writing, but don't feel like you've got to hit that one, because there will be another call that comes round.
Thanks, Kate. And we've got a question in the chat. There's a lot of funding opportunities, and you're absolutely right. NIHR is primarily focused on England, and you're right to say that some of the NIHR funding is extending to Scotland. You're right that the Pain Relief Foundation does fund research from all devolved countries and devolved nations. But does anybody know any? And I'm thinking in terms of the cancer charities and the charitable funding, that would be the same. But I'm going to open that out in any specific funding that's Scotland related. There's the British Pain Society research grants as well. I'm thinking, Kate, do you want to mention those?
Yes, the Clulo has just been awarded, as I understand it, for this year. I think Joe might correct me. I think that probably will be advertised again, but I don't know when.
That the Mildred Clulo Award.
Yeah, we run that every 2 years, actually. So the next run would be in 2027. But we are looking at other funding options that we can bring in. We've just put them on hold to do our review right now.
But if you think about the advice, what not to do, is don't rush an award. So 2027 is a good thing to aim for. It's like funding that's coming up in 26 and 27. My other advice would be to look at the grant making. Like, look at small grants, look at your professional bodies, and think about, there's a surprising number of small grants available. But I absolutely take your point. I'm just quickly reading. Oh, absolutely, fingers crossed.
I think
for building collaborations. Yeah, so absolutely.
In Scotland as well, the Chief Scientist's Office does funds academic fellowships and early career health researchers as well. So I think that's an equivalent. And then there's also the Medical Research Scotland as well that is a big charity as well that does lots of funding there.
Thanks very much. So I am determined to keep us to time, and we are finishing in 3 minutes. So this is the last call for any last minute questions. And whilst I'm looking at the chat, I'm going to finish with a thought of that. We've talked, the other uniting theme in all of the presentations is failure to achieve research where the research is rejected. And I'm really glad that you did not use that word of saying I failed to get that funding. Is your funding was rejected, because there'll always be somebody who doesn't see your worth. There'll always be somebody who does not see the worth of your research. But the most important thing to concentrate on is making sure that that someone isn't you. And that you need, because if you don't believe that you can, and you don't believe that your research is a valuable contribution, then you won't be able to convince anybody else.
I think that's a way to finish. That's a nice end, I think, to the webinar for the evening. Fantastic. Just my job is just to thank everyone so much. It's been really interesting to listen to, but really inspiring as well, and very different journeys and very different research. But yeah, just brilliant. Thank you so much for giving up your evening to speak, and thank you for people who have joined us to listen this evening as well. And I know that people will also access the recording that will be made available afterwards. So please enjoy what is left of Wednesday. Is it Wednesday? Wednesday evening. And thanks again.